this patient in 1898. In 1906, he demonstrated that treatment results of more than 300 cases in Chicago, but his surgery was not acceptable in that era due to high incidence of morbidity and mortality. Then in the United States, the Verdium surgery was revisited by Meek, professor of Harvard Medical School in 1944, and then it became popularized. So before I go to surgery, just what is the concept of hypogastric plexus, where it is just near the sacral promontory. This is the superior hypogastric plexus, divided into right and left, forms inferior hypogastric plexus. You can see the approximation of the right hypogastric plexus, hypogastric nerve with the ureter and left ureter. So these, you just try to imagine how close are they with the ureters and to the rectum. In coming slides, I will show the spaces. So again, a diagram showing common iliac bifurcation. These are the plexus. Again, the same diagram. Just an idea where the plexus are in the pelvis. So before I go into the steps or description in the mastectomy, this you should know and you should remember. If it comes, you should at least put not 3, at least 2 or 1 classification, especially Power-Routledge and Marlowe, the 2 followed classification.
थोड़ा zoom करो ना, zoom
ये अभी दिख रहा?
कुछ तो बेटर हुआ.
तो Power-Routledge and Marlowe you should remember. सेम ही है, बस इनमें थोड़ा आगे पीछे का फर्क है. जो Power-Routledge class 1 है, extrafacial that we do. The identification of uterus through transparency is only way to identify the ureters. इसमें हम ureteric tunnel नहीं करते हैं. The uterine artery is lateral, is sectioned and ligated. Uterosacral ligament, cardinal ligament are not removed. Okay, in this we go as close as possible to the uterus. It is also called a simple hysterectomy in URTC and in Marlowe also. But in Marlowe, there in Power-Routledge, no vaginal portion is to be excised. But in type A Q&M classification, removal of vaginal portion is to be done. Otherwise, rest is same. Here we identify ureter by palpation only, without dissection. No other ligaments are dissected or cut it. Clear? Now then we come to class 2 and type B. So class 2 is also called Verdium, modified radical hysterectomy. And here we dissect the uterus in the paracervical region, okay, but are not resected from pubovesical ligaments. So a bit more dissection than type 1. The uterine artery is sectioned besides the medial of the ureter. Uterosacral ligaments are excised midway. So इसमें रखना क्या याद है कि we are I will show the ligaments. What are the ligaments? We dissect in the midway, not from the origin of ligaments. Okay, and in Verdium we do pelvic lymphadenectomy. Okay, removal of upper third of vagina, 1/3. That is class 2 of Power-Routledge. In Q&M, type B is subdivided into B1, B2, almost same. 10 mm of vagina. You divide the partial resection of uterosacral ligaments, and B1 without removal of lateral paracervical node. B2 removal of lateral paracervical node. Here I will define all coming steps. What is type 3? Type 3 in Power-Routledge is the Meek's classical radical hysterectomy. Here we dissect the ureter complete. We make a ureteric tunnel till it enters into the bladder. Okay. Ureteric artery are cut off from the origin. All ligaments are to be cut off from their origin. Okay. Removal of upper half Before it was 1/3, now it's upper half. And pelvic lymphadenectomy is done in 2 and 3 in both cartilage. In type C, Q and M, it is important because here the concept of nerve preservation comes. In type C1, almost same, no difference at all that much. Here in type 3, they have told 1/2 of vagina. Here they have told 15 to 1.5 2 centimeter vagina with preservation of autonomic nervous system. That means type C1, Purlo Marlowe, C1 is the nerve preserving radical hysterectomy, C2 is not. Is that clear till now? Okay.
वो 2 वाले में मीडियल टू यूरेटर था।
किसमें?
2 वाले में।
हाँ।
और इसमें लेटरल टू यूरेटर है।
लेटरल हमको ज्यादा जाना, we have to go to the origin, to everything to the origin. Type 3 a more radical surgery.
टाइप 2 में यूट्राइन आर्टरी जहाँ क्रॉस करता है ना यूरेटर,
वहां तक जाना है।
ब्लेडर तक नहीं जाना है। वो जो आगे जो प्यूबो वेजाइकल लिगामेंट, प्यूबो वेजिनल लिगामेंट होता है, वो उसको कुछ नहीं करते हैं, खाली लेटरल पैरासर्विक्स डिलिनेट करते हैं, यूट्राइन आर्टरी उठाते हैं, आगे टनल नहीं बनाते।
तो यूट्राइन आर्टरी जो काटते हैं, दैट वी आर कटिंग लेटरल टू यूरेटर और मीडियल टू यूरेटर, ये मैं पूछ रहा हूँ।
In type 3 lateral.
और origin, you said origin.
Yeah, you can see here. Just
what I heard is birthings में
besides medial to ureter.
birthings में just lateral to ureter. Type 3 में origin में करते हैं, मैंने ऐसा सुना।
Type 2 में इधर लिखा है besides and medial to ureter in type 2.
Medial to ureter, ठीक है।
Type 3 में lateral. Okay. Type 4 is more radical. Okay.
तो नर्व हम लोग कहाँ काट रहे थे पहले, जो अब बचा रहे हैं, ये मेरे को बताओ एक बार।
कौन सा नर्व?
ये जो तुम बोल रहे हो ऑटोनॉमिक नर्व प्रिजर्वेशन।
मैं आऊंगा उस पे। हम जो अगर हम नर्व प्रिजर्विंग है, in pure EORTC they don't define nerve preservation. It is Curlo-Marlowe classification that defines nerve preservation. वो कैसे preserve करना, I will come into that. Okay?
चलो आगे चलो।
मतलब you have to make spaces to identify them and to preserve them. Is that okay?
Yeah.
If nerve preservation comes, that is only defined in Curlo-Marlowe classification. Others classification don't define, they are simple radical hysterectomies without nerve preservation details. Okay. Fine. So type 4, it differs from previous class according to the following aspects, which gives a higher radicality: complete dissection of uterus from pubo-vesical ligament, umbilical vesical artery is sacrificed, removal of 3/4 of vagina. Okay, almost same in QRTC. In Curlo-Marlowe, it is D1, D2, full resection of paracervical tissue up to the wall of pelvic bone, together with the hypogastric vessels, exposing sciatic nerve roots, ureter fully ambulated. D2, sorry, resection of muscles and adjacent fascia is there. Rest is almost same. Resection indication or the indication of radical hysterectomy. Sorry. So indication of radical hysterectomy. Initially, the indication was already for cervical cancers. Later, then it came into the hysterectomy in this bladder, uterus also. So, according to NCCN guidelines of 2019, recommends a radical hysterectomy for stage 1B. 1B means less than 2 centimeter. 1B2 means 2 to 4 centimeter. And 2A. And selected 1-3B of cervical cancers. Okay. And Japanese Society of Gynec-Oncology guidelines recommends two treatment modality of radical hysterectomy and concurrent CTRT as a choice of treatment for 1B to 2B cervical cancers. It also recommends a nerve-sparing radical hysterectomy for 1B, 2A1 cervical cancers. And nerve-sparing radical hysterectomy is recommended for selected cases of 1B2 that is greater than 4 centimeter, 2A2 patients, that means upper vagina with tumor centimeter more than 4 centimeter, and that the nerve procedure does not impair the radicality of the surgery. How do we pre-op evaluation? How do we do? Same as that generalized patient, that what we do. Heparin has to be given. Before we proceed, we have to do examination of anesthesia. Okay, see the extension, any paracervical involvement. Suspicious disease beyond the cervix vagina should prompt abandonment of the procedure and subject the patient to radiation. The typical route of radical hysterectomy is abdominal, laparoscopic or robotic. The patient should be positioned in a low dorsal lithotomy position using stirrups. The abdomen is prepared. Rest, you can do, and some say you do fen steel, Maillard, some say midline incision. Then uterus is grasped with Cocker's clamp in each corner so that the cephalic tension can be placed in the uterus. The round ligaments are sutured or ligated, divided with absorbent sutures, vicral or chromic catgut, what you use. The broad ligament is opened in the cephalad direction and caudal direction, laterally to the gonadal vessels, and the ureters are identified. That's the first step. So while you make the flaps, during that broad ligament, the flap towards the ureter will go medialize, and laterally the vessels will be there. Go down, you will just find the ureters first. So after finding ureters, the uterus elevated out in the pelvis and manipulated by two Kelly's clamps placed across the broad ligament adjacent to the uterus fundus, encompassing the round ligaments, fallopian tube, uteroovarian ligament on each side. This is again the same. This is just a figure. So in this, you can see. So I will try to highlight it. Can you see this cursor of mine? Hello?
Yes.
Okay, so this is the two spaces we have to first create. First here, laterally there will be the vessels, medially there will be ureter with a flap, and there will be space here. This is called pararectal space 1. It is further divided into 2. And anteriorly, you will make a space that is called paravesical space. Okay, fine. These two, in this paravesical space, the obliterated umbilical artery will be there. Laterally, there will be external iliac vessels. Medially, there will be bladder. So these two spaces, there will be a tissue in between that is called cardinal ligament or paracervical tissue when it goes down. In this tissue, this area is called cardinal ligament, in which your uterine artery is there. Okay, fine. So this is how we make uterine tunnel after making these two spaces. Just go into it. So this is the same. This is the lateral parametrium. I will just parametrium is of divided into ventral parametrium, lateral parametrium, and dorsal parametrium. This is the lateral parametrium, the cardinal ligament containing paracervical tissue. Okay, this is the ureter. We have made these two spaces I defined to you, and medially there is a rectum. Your problem. So, now concentrate here. So lateral paravesical space clear to you. Okay, these are the vessels. This is the space, pararectal space. It's concentrated on the ureter. the pararectal space lateral to ureter is called Latsko space. Okay, fine.
Fine.
The space lateral to ureter, pararectal space is called Latsko pararectal space. And again, description of the same, what I told you. This is the paravesical space. This is the Latsko parietal space. You can see the ureter, and the lateral space is called the Latsko parietal space. So, see, the space medial to ureter is called Okabayashi space. Okay, you can see the ureter is there and along the nerves are with it. Is that clear till now? I will in subsequent pictures show you. These two spaces you remember, Okabayashi space just lateral to the rectum, and then it is ureter. Then after lateral to ureter, it is Latsko space. Okay, so in neuropreservation, these spaces are important because your hypogastric nerve is between Latsko space and Okabayashi space. Fine.
Fine.
Is this much clear?
यूरेटर को मोबिलाइज नहीं करेंगे तो अपना बच जाएगा नर्व, है ना?
हाँ, नहीं, उसको मोबिलाइज करना है, तभी आपको नर्वस प्लेक्सस मिलेगा. This picture will make you a bit more understand. Now you can see clearly where is the ureter, where is the hypogastric nerve, where is the Okabayashi space, where is the Latsko space. I think this picture will make you a bit more clear where you should find the nerve. See, this is the pararectal, immediate pararectal space of Okabayashi. This is the rectum here, then Okabayashi space, then hypogastric plexus in that fold, then ureter, then Latsko space. Then after Latsko, your vessels will come. So from medial to lateral, I will go. There is a rectum, there is Okabayashi space, that is plane of heaven. There is nothing there. After that, there will hypogastric nerves will come, then ureter will come, then Latsko space, then vessels will come. Is that this thing clear?
Basically, nerve lies in the dorsal parametrium, deep to the deep uterine vein is there. It lies deep, so it lies deep to it. That is, if we tie those veins and sit there, it is C2 then. If we don't tie and remain above, then it is C1.
Okay.
Deep uterine vein.
Yes.
कहाँ है
So
वो?
it is in dorsal parametrium. There are three parts of parametrium: lateral, dorsal, and ventral. So
here we are discussing dorsal parametrium. This is dorsal parametrium.
Yeah. So in dorsal,
Okay. Shall I proceed? So a more pictorial diagram of these spaces. So just visualize the space. You will come to know what I am trying to describe to you. This is anteriorly bladder. Sorry. This is bladder. Immediate to it is vesicovaginal space, then cervix, rectovaginal space, the rectum. Okay. This is cardinal ligament or lateral parametry. Okay. This is Okabayashi space, just lateral to rectum. Lateral to it, that's the space. Then again, that cardinal ligament. Anteriorly paravesical spaces. Is that clear?
yes.
So these are avascular potential spaces that allows the peritoneum or the pelvic side walls to be mobilized safely, thus exposing pelvic side wall vessels and the course of ureter. The pararectal space is bounded by external iliac artery, internal iliac artery laterally, the ureter medially, and the cardinal ligament anteriorly. The paravesical space is bounded by external iliac laterally, the bladder and the superior vesical artery medially, and the cardinal ligament posteriorly. Clear? Clear paravesical parietal space?
Yes.
Any confusion? I can repeat it. Soumya, hello.
थोड़ा दिमाग घूम
Clear
रहा
this?
है ठीक है
So
फिर भी
here,
better.
Here you can also take some time and tell that ventral like vesicouterine ligament, na? It is also
yeah. This is a ventral part is ventral vesicovaginal space that we usually first step. We usually take the bladder up, create that vesicovaginal space. Usually we do first, but I have tried. They don't. Many people don't tell that they have first create spaces laterally, then they go anteriorly at the end. But here we do first. We take the flap anteriorly. I don't know what
देते
you
हैं
do,
बाबा, अगले दिन किस दिन देते हैं,
but
अभी
they are
कैश
saying
नहीं
do
है हाथ
first
में,
these spaces,
कैश
delineate the
निकालेंगे तब
spaces,
देंगे.
delineate the lateral parametrium first, go then to the anteriorly and posteriorly.
specific node and then take.
Yeah, they say node. Most of everybody says assess the node, then go for resectability. If you see this diagram, your spaces will be a bit more clear.
Yes.
See, paravesical space anteriorly laterally there are external iliac vessels. Medially there is bladder, posteriorly cardinal ligament, which I told you. Okay.
Yes.
Okay.
When you are able, you first these two spaces you delineate, you then try to feel the ureter or palpate. If you are not able to see ureter, there is a classical snap. What you do, you take the medial flap, just like a guitar, you taut the flap, and just like a guitar string, you feel a snap, which is produced by dragging your finger and the thumb across that flap, medial flap. Okay, near rectum that we create. You will feel a snap, that is the ureter, and then start dissecting it. Some surgeons now proceed with the pelvic lymphadenectomy. The rationale behind that, the findings of microscope positive pelvic nodes would result in abandonment of the operation. Two or more difficult parts of the procedure are dissection of uterine artery and ureter. The cardinal ligament is dissected below the uterine artery. The cardinal ligament is this, which I showed you. So then we proceed to dissect this ligament and try to find out uterine artery as we usually do. So urethral dissection then commences. The ureter is dissected off from the peritoneum near the uterosacral ligament, taking care preserving its surrounding adventitious blood supply. A small VV vessel is often seen adjacent to the ureter that should be preserved. Ureter is then freed from the peritoneal attachment. This is facilitated by cephalar traction of the ureter and posterior traction of uterine adventitia. The uterus should not be handled directly. The tunnel through the ureter courses. Lateral anterior cervix is then dissected and freeing of ureter is done. The cardinal ligament, which is very important because cardinal ligament is the lateral parameter. It is very important because what is cardinal is the web of tissue between paravesical and pararectal space. Between pararectal and paravesical, which is just a web of tissue. I will go back to make you revise. This lateral parameter, can you see? Anterior paravesical space, pararectal space. The cardinal ligament is this web of tissue. Here this is cervix or uterine border. These are vessels. So this ligament is cardinal ligament. Right? So the cardinal ligament is a web of tissue between paravesical and pararectal space. Is palpated to evaluate any local disease. So before you dissect it, you just put a finger and thumb. See any node is there. If node is there, then again you can take and send for frozen. Again, it upside is the disease. Local or tumor extension is there. That means lateral parameter is normal. Again, the stage upside becomes 2B. So the local tumor extension into the paracervical tissue is generally an indication for abandonment of radical hysterectomy. The posterior leaf of broad ligament is placed on medial traction and the ureters are dissected from the attachments to the lateral side of uterosacral ligament. This again, you mobilize the ureter bladder as we all do, nothing special in that. Then you go down as much as possible. Depending upon what type of hysterectomy you are planning, you will do how much of vagina you take out. That determines your type of radical hysterectomy. So this is about that. Some word about pelvic lymphadenectomy. Pelvic fend is almost always performed in conjugation with radical hysterectomy for cervical cancer. Complete removal of pelvic node rather than sampling is the goal. Operation is accomplished with sharp dissection, electrocautery or Hemlock clips are often used for hemostasis and possibly to decrease risk of lymphocysts. The peritoneum is open from mid-comal iliac artery to deep circumflex iliac artery, that is the proximal and distal extent of our lymphadenectomy. Anteriorly, it is deep circumflex, posteriorly common iliac. These landmarks constitute of iphyllid and caudal limits of dissection, respectively, as self-retaining retractors used to expose pelvic side walls. Retractor medially, dissection begins just medial, so the medial extent, the lateral extent genitofemoral nerve, which courses lateral and parallel to the external iliac artery. The lymph node bearing tissue are mobilized medially of the external iliac artery and vein. The obturator forces enter just below the external iliac vein. The surgeon should be aware of possible accessory obturator vein taking off from external iliac, present 10% of population. The branch may be ligated to facilitate exposure of obturator fossa. Dissection is carried under the external iliac vein towards the pelvic side wall to the psoas muscle, separating the node bundle from the vein completely. A vein retractor may be carefully used to retract the external iliac vein for exposure. The external iliac vein may be taken separately or in continuity with the obturator nodes. Obturator nodes are then mobilized off from the obturator nerve, which courses in the middle of the obturator fossa. It is important to avoid injury to the nerve as it is vital for abduction of lower extremities. Care should be taken to remove all lymph nodes above the nerve, including those genu between the external and internal iliac vessels, and most distal aspect of obturator fossa, proximal to obturator foramen. The lymph node bundle can often be grasped and pulled medially, sweeping it from the obturator nerve and internal iliac vessels with a fly incisor. This allows the obturator nodes to be removed, often as a single specimen without cutting any tissue, thereby minimizing the bleeding and the risk of obturator nerve palsy. There may be few obturator nodes below the nerve, but significant bleeding can be encountered in this space, so generally it is not recommended to remove the nodal tissue which are below the obturator nerve. The distal common iliac nodes are then removed just lateral to the common iliac artery, particularly taking care on the right side where right common iliac vein is lateral to the artery. Once dissection is complete, genital femoral nerve, obturator nerve, superior vesical artery, ureter should all be clearly visible and uninjured. It is important to place a drain, close the peritoneum. These steps have been found to decrease the lymphocyte formation. Hemostasis is confirmed and fascia is closed with the continuous or delayed absorptive sutures. Okay. हेलो सो गए?
नहीं, जाग रहे हैं।
तो इसमें इंपॉर्टेंट ये है, क्लासिफिकेशन याद रखना है। मुझे एक बात समझ नहीं, वो टाइप 1, टाइप 2, टाइप 3 में कौन सा वाला बोलते हैं? यूजुअली जनरली बोलते हैं टाइप 1, टाइप 2, टाइप 3।
वो हम ये
इसमें से कौन सा?
पावर फ्लूइड्स बोलते
हाँ?
हैं, पुराना वाला, ये वाला बोलते हैं।
ये वाला ना?
क्वेरलोमैरो तो नहीं बोलते हैं, B1 C1 कहाँ बोलते हैं।
ठीक।
अभी
ओके।
डॉक्टर राकेश रोज हिस्टेक्टमी कर रहे थे, तो बता पाएंगे बेटर कौन कौन सी कर ली डॉक्टर राकेश आपने।
मजा आता वहां पे सिर्फ काटना है, बाहर आना है।
नहीं, गायनेक पोस्टिंग करने गए हैं एंड में सीखने गए हैं, तो हमने कहा सीख लेते।
ठीक है, अच्छा से बट एक मोलम करके एक है यूट्यूब पे, वो जबरदस्त न्यूरो प्रिजर्वेशन उसके वीडियो है, बहुत खतरनाक, देख लेना वो कोई, मतलब उसको देख के लगता मोलम है मोलम।
एक लिंक भेज देना ना, लिंक।
अरे मतलब उसका जो सीजर है उसको कॉटरी है, सीजर ओपन है, रोबोटिक नहीं है।
ओके।
मतलब उसको देख के लगता है ये, लेकिन ये स्पेसेस बड़ा होना चाहिए, वही इंसान बोलते हैं क्या बोल रहा दूसरी दुनिया में।
वो स्पेसेस का एक अच्छा पेपर है, वो मैंने जब मैं गायनेक पोस्टिंग में थी तो मैंने पढ़ा था। वो पेपर अच्छा है।
ओकाबायाशी का।
हाँ ओकाबायाशी वो पेपर, उसमें बहुत अच्छे पिक्चर भी है, ऐसे ही है
लेकिन
उसका।
जब तक ये इंसान वीडियो नहीं देखे समझ नहीं आते ये क्या चल कर रहा है।
अरे वो वीडियो देख के भी नहीं समझ में आते, जब खुद करते हैं ना तो मेरे को कोई स्पेस, अब वो लेटरल टू मीडियल टू यूरेटर देखना है स्पेस, ये तो मैं सोचा ही नहीं था। स्पेस सब बना देती हूँ मैं। कौन
तो
सा
उसी में वीडियो
कौन सा स्पेस है वो नहीं पता। लेटरल टू यूरेटर और मीडियल टू यूरेटर देखने में वहाँ बस ये है कि हाँ जाना है, लेटरल से जाना है मीडियल की तरफ, मीडियल वॉल में वो रहता है, यूरेटर रहता है।
हाँ वो सबको पता है, लेकिन वहां पे भी दो स्पेस। चलो ज्यादा अभी पहले सिंपल सिंपल चीज ना, बाद में कॉम्प्लेक्स। पहले कॉम्प्लेक्स चीज तो लाइफ कॉम्प्लेक्स हो जाएगी।
नहीं नर्व बचाने का मैं सोच रही थी, नर्व क्योंकि मेरे को तो वहाँ इतने सारे नर्व दिखते हैं कि मेरे को समझ में ही नहीं आता क्या बचाऊं क्या रखूं।
और कौन से नर्व देख रहे हो आप?
अरे जब रेक्टम करते हैं तो नहीं दिखते भर भर के नर्व नीचे जाते हुए पेल्विस में।
रेक्टम के पीछे है ना, तो ये तो रेक्टम और इसके बीच में की बात है, और लेटरल वॉल की बात है।
वही बोल रही हूँ, तो उसमें तो मुझे बहुत कंफ्यूजन हुआ। अभी मैं आजकल रेक्टम कर रही हूँ ना, तो मेरा ध्यान उधर है।
अच्छा
आईएम में तो बचा लेती हूँ, उसके बाद का जो नीचे इतने सारे प्लेक्सेस जाते हैं उसमें कौन सा बचाना है कौन सा रखना है, बहुत कंफ्यूजन है।
सब बचाओ।
सब बचाओ, अभी सब तो नहीं बचा पाती मैं।
और कोई है?
एनी नेक्स्ट प्रेजेंटर?